Okay. If anybody else is in the waiting room, I'll let them in as they come. But hello and welcome. A few housekeeping things before we get started. Feel free to have your videos on or off, whatever you are most comfortable with. We just ask that you attend to the material being presented, but please keep yourselves muted throughout the presentation to limit background noise and distractions. If you have any questions or comments, feel free to use the raise hand option or utilize the chat. There will also be time for questions at the end. All right, so my name is Allie Shipman. I am the Parent-to-Parent Program Coordinator here at the CED. You're all here today for our virtual speaker series, all about ABA, where we welcome Charlotte Arrington, Haley Ramsey Johnson, and Devin Huffman, co-founders and board-certified behavior analysts at Key Learning Autism Center. So welcome, Charlotte, Haley, and Devin.
Thank you.
Thank you. So we'll share our screen. All right. And I'd like to get that. There we go.
Okay. Does everybody see everything okay? Hopefully.
We can't hear anything. So
No, we
just
can't hear anybody. So hopefully if you guys have any questions, you guys will put them in the chat and then we'll get to them as we see them and we can kind of answer our questions at the end. So as she already said, we are going to go over applied behavior analysis. We are from Key Learning Autism Center. We founded Key Learning around 7 years ago. And before that, we worked at the CED actually as Lynch trainees from 2016 to 2018 when it was the Intensive Autism Service Delivery Clinic, which was in the basement of the CED. Then it transitioned to the Neurodevelopmental Center. The three of us have a little bit over 10 years of experience of working with children diagnosed with autism spectrum disorder. So we're excited to talk to you guys today. So first we're going to go over just like the basic gist of ABA. So ABA is a systematic approach for influencing socially important behavior through identification of reliably related environmental variables and the production of behavior change through those techniques and findings. So what that really means is ABA is kind of like a blanket term for a bunch of evidence-based interventions. And it's very systematic. So, as the professionals, we observe what occurs before the behavior happens, which is the antecedent, or what occurs after the behavior happens, which is the consequence. So, we utilize those two findings to change behavior. We make sure that the behavior that we're changing is socially important. So, it should always, make improvement in the person's life. We make sure that we're observing all observable characteristics of the environment rather than thoughts or feelings, so that those things are observable and measurable. And ABA is backed by a lot of longstanding evidence, and it has the longest history and most extensively documented evidence base to support its efficacy in the treatment of autism spectrum disorder. So, ABA is implemented through individualized goals for the child or the person who's receiving ABA. So, typically, we're targeting communication, restrictive or repetitive behaviors, or social skills to improve their life. So, each of those things are related to the diagnosis of autism spectrum disorder. We make sure that we're focusing on positive reinforcement to increase the appropriate and safe behaviors. And we identify the events before or after a behavior, like I talked about previously, to develop plans or increasing or decreasing these target behaviors. We make sure that we're always breaking the skills down into small steps so that they're achievable. And we target generalization across different environments for consistency as well as maintenance. And we always have ongoing collaboration with the families or other service providers. So here, I'm going to go over some misconceptions about ABA, and I'm going to talk a little bit about like why those are misconceptions. So one of the biggest misconceptions is that ABA claims to cure autism. So ABA does not cure autism. We make sure, like we said previously, that we are just providing meaningful therapy that improves someone's quality of life. So whether that be increased communication, work on toilet training, decrease some challenging behaviors, like if the child were to have self-injurious behavior. So really, we're just giving them the tools for independence in their own life. Another misconception is that we focus on teaching children to mask and reduce all self-stimulatory behaviors. So that's kind of something that's talked about kind of a lot right now in the media, that we specifically work on reducing stimulatory behaviors, and that's not true. We only reduce self-stimulatory behaviors if it's majorly impeding upon learning or if it's a danger to that client or others around them. Another misconception is that we don't consider the child's emotions or other unobservable behavior. So we do take data on things that we can observe and it can be easily tracked and changed, but we always consider the child's emotions or other things that they might have going on, like whether they're tired or sick or things like that. Those things are always considered. And we work on teaching the child to be able to communicate their wants and needs versus just going off of like if they're crying or if they're upset, we try to make sure that they can communicate their needs. The next misconception we wanted to talk about is that it's only effective for people diagnosed with an autism spectrum disorder. So, ABA is effective for everybody. It's effective for people of all ages. It's effective for animals. It is a behavioral science that can be applied to anyone. It is not only for problem behavior. So, really, we mostly focus on increasing things like communication and daily living skills, as well as skills for independence. We work on pre-academics, so it's not only for decreasing problem behavior. It's also does not produce responding only under a natural or contrived situation. So that is a big misconception, is that we only work on things in a very strict, discrete child teaching format and it doesn't generalize to school or other places. We are always targeting behaviors to make sure that they are useful in that person's life and that they can generalize to real world situations. And we're programming to make sure that we are giving the client the tools to be able to use these things other places. So modern ABA has become more naturalistic and flexible and person centered by developing meaningful skills in the naturalistic environments. So we're not, like I talked about earlier, we're not just going to work on discrete trial teaching in a clinic. We're going to make sure that these skills are used in school or at home. ABA is often play-based and uses learners' interests and hobbies and activities. We make sure that we have a greater emphasis on communication, autonomy, and quality of life. The ethical standards have been increased, and there's an emphasis on assent and dignity.
You're doing strange things.
We have integration with other fields and providers, as well as the learner, family, and caregivers. Was there a question? Sorry, we just got a little bit of noise, so just want to make sure we weren't missing something.
No, I think they were just getting on, just logging
Okay.
on.
Sounds good. So, applied behavior analysis, as far as the professionals that are working in this field, the first one that is going to be implementing most of the direct therapy, at least in our setting, is a registered behavior technician. So, a registered behavior technician either has a high school diploma or a GED. They must be supervised by a BCBA. Then there's a board certified assistant behavior analyst. So, that person needs to hold a bachelor's. And then there's a board certified behavior analyst, which is what we are, and that they hold a master's. So they have to supervise both the BCABA and the RBT. For a BCBA, we usually have either 2,000 or 1,500 fieldwork hours, and that depends on how many supervision hours you get. And you need to, for all of these, pass the exam from the BACB. And then there's also a board certified behavior analyst that's a doctorate. So those people have a doctorate in a related field. And all of the applied behavior analysis professionals are guided by the BACB and then the ethics code for behavior analysts. So This is a good resource to have, bacb.com. Families can search and find behavior analysts in their area. So we're going to talk about the 7 dimensions a little bit. So these were outlined by Bearwolf and Risley, and they outline the field standards for quality research-based and effective behavioral interventions. So these are the 7 dimensions that interventions must possess. So first off, they must be applied. So the interventions need to be applied to behaviors or problems that have social significance in the child's life. So for an example, something that would be socially significant, we work to improve communication skills because it is important for the child to be able to request their preferred items, activities, and items needed to meet their basic needs. So the intervention must also be behavioral. So behavioral is the target modification and must be observable. So everything that we're targeting, we must be able to observe it and take relevant data. All the interventions have measurable goals and they're based on objective data and observable behavior. So an example of this would be that the child will request 55 times and independently in a 3.5 hour shift, and the therapists collect data either with tallies or a golf clicker. And at the end of the day, that data is graphed so that we can make decisions based on that. So the next one is analytics. We must be able to identify functional relations between the behavior and environmental variables. So the intervention and then the behavior change. And like I said earlier, the data is collected to track this behavior change. Protocols developed to be followed so that treatment areas do not intervene with behavior change. So everything needs to be written out and clear so that we're making sure that everybody's on the same page and implementing the same protocol. An example of this would be that the therapist implements a visual schedule consistently and collects the data on successful transitions before and after the intervention. So we also have to make sure that our interventions are conceptually systematic. So our interventions are evidence-based, they're based on behavioral principles. So some examples of things that we would use would be modeling, prompting, positive reinforcement, shaping, and chaining. We strive to understand why behavior changes using we strive to understand why the behavior changes using those basic principles. So kind of like what I said earlier, that ABA is a term for an umbrella of interventions. So there's a variety of interventions we can use. So some examples of that would be BCBAs create protocols and procedures that are based on empirical data and research that's within our scope of practice. So we're always going to be making sure that we're working with a client, that it's within our scope and that it's not something that is completely novel to us.
We also want to make sure that our interventions, as Haley was mentioning, are effective and produce long-lasting, socially significant change in their life. So everything we do, we want to make sure it's improving their quality of life. For example, if they can communicate in clinic that they need a break, we want them to also be able to communicate that at home or at school. Yeah, if you want to. Okay. And that generalization component is important. That's why it's always great to have parents on board and other service providers on board, schools on board. That way the child has the same expectations in all environments to make it easier for them to engage in those behaviors across the different environments. So each time one of our clients learns a skill, we're making sure that we are testing that skill across different materials or people, places, and situations as much as we can in our setting, and staying in touch with parents and teachers on how the child is doing in those places too. So for example, a child can ask for an iPad at home and remain calm. We want to make sure the same thing is happening at home. Our interventions should also be technological, and that means everyone can implement them. They can read a protocol, we design them in a way that's easy to understand, and if they're not, then we change them. And here is an example of one of our protocols we have on our data collection software, Motivity, that's made things really easy for us, and parents can look at this data and look at the SOAP notes at the end of the day, but just a simple protocol with how to set up the intervention. This one is for identifying shapes, and the therapist is able to enter were they correct or incorrect, how many error corrections, and we'll get into that a little bit later. But if a tech or parent tells us, hey, I'm not really understanding this, then it's our job to fix it so it is understandable. And as we mentioned earlier, all of us use ABA every day, probably without realizing it, but some of the other fields where ABA could be implemented are education, organizational management. We are always implementing ABA and trying to put in effective interventions for our staff. And then also in sports and athletics, health and wellness, addiction, dementia care, animal behavior, and then it can also be effective across other diagnoses, OCD, ODD, ADHD, and we have a lot of clients here who have comorbid diagnoses. So ABA has been backed by research and promoted by the CDC, the Surgeon General, the National Standard Project, and the data is also always being improved, and there are studies being done all the time, but there are things that impact the effectiveness of ABA, which we'll get to. It is not something that works the same for every child. So we stress this all the time. It is crucial for children to start ABA in that 2 to 6 range because of the neuroplasticity of their brains and how they're forming new connections. The intensity and duration of therapy can also impact the effectiveness. It seems like the average is 25 to 40 hours per week. A lot of our clients here come 3 full days, which ends up being around 18 hours. And then the average age for a child to be in ABA therapy is 1 to 3 years. But also, they should be receiving this therapy at home too. And a lot of our clients stay here for that range. As we've stressed over and over, family involvement is crucial. And so it's our job to set parents up for success, constantly meet with them and understand their needs at home, because sometimes what we see here is completely different than in home. So we need to work together to form impactful interventions. And then every child also has individual differences. Like it was mentioned earlier, although we're not taking the same data on unobservable behavior, every day for all of our kids, it's how did they sleep? Is something upsetting their stomach? What other things are going on? We have, maybe some clients that could have brain tumors or other genetic conditions. There are just always so many factors to consider, and that impacts ABA as well. And then also the BCBA's experience. Not one provider is going to be a good fit for every child. Just a little bit about how it looks like here to bring in a new client. We first meet with the parent, and a technician plays with the client, and we do the intake assessment. So we're talking with the parent about what their goals are, maybe about deficits, the child's strengths, while also taking data on the child for our assessment. And one of the many assessments that we use is the Verbal Behavior Milestones Assessment Program, because a lot of our clients here fit that age range, just to see where their skills are developmentally from that 0 to 4 range. Then we're able to, based on parent input and our observations and our assessments, to create individualized goals for each client. And then from those goals, we develop individualized programs with different prompting methods, different materials depending on what they need. So at first, we really just need to get to know the client and pair with them and see what they're interested in. And then we are taking continuous data collection for all of their goals to update them and edit them as needed. And we typically complete that assessment every 6 months to see the change. Discrete trial teaching is one of the many evidence-based practices that we implement. I know a lot of people think that ABA is just that discrete trial teaching at a table, but that is far from the truth. So DTT is one of the many strategies, and we'll get into that a little bit later. And you can use DTT to teach any type of skill. It's just about breaking down the skill into smaller steps and more manageable steps. But we also use prompting. So whether that's modeling, gesturing, light guidance, depending on what the learner needs, we implement task analyses for those skills that have a lot of steps. That way we're teaching the child to follow that routine in a manageable way for them. Video modeling, reinforcement is based on their needs for how often reinforcement is provided or what type of reinforcement is provided. We implement differential reinforcement to reinforce a more appropriate behavior and reduce problem behavior. We're constantly shaping to get that skill um, to how we want it to be. So with communication, we might start with a sound that goes to a single word, that goes to a 2-word phrase, and then we're working to fade out our prompts because we want the child to be able to respond independently to the world around them. And then it looks like there are modules on that website. I don't know if they're still there, but that's something to check out. So in discrete child teaching, which is one of our main strategies, this can be applied to any skill, but in general, you're taking it one step at a time, breaking down the task into smaller parts. And then that includes multiple opportunities. So say, for an example, if we're teaching colors, we might start with 3 colors at a time instead of starting with 10 colors at a time. But once again, if the client is at a spot to learn more than that at a time, then we will. But typically it's 3 targets. And then we change our targets systematically. So we're looking at how are they responding to each of these targets? Should we add one, remove one? And we're looking at the data every day for how they responded. And then it's all based on the instruction, then the behavior that occurs after the instruction and the consequence. So if they respond correctly, reinforcement is provided, whether that's after every correct response or on a schedule. If there's an error, then we may implement error correction, which is just extra practice opportunities, or maybe we just prompt the correct response and move on. It's all based on what's best for the learner. And then here are some examples across different things. Okay, so in that example, oh, um, you hear the tech give the SD or the instruction, where's the sticker, and then she gives the learner a few seconds to respond. If he responds correctly, she's providing praise. If he responds incorrectly, she's modeling. And then she implemented light guidance at one point, and so she gave him an independent chance in the next opportunities, and he was doing it on his own. Sure.
There's no sound to the videos. We can see them, but we can't hear them.
Oh no.
Well, you can explain kind of what they're doing there.
So,
We'll stop
and
there.
she did a few different things here. So at first she sorted it and she's labeling mom, dad, and Sarah throughout. And then she gives the learner an opportunity to hear the name and touch the person. And at the end, she's holding it up and they're labeling the people. And so for both of these with the pointing, the main goal is not for him to point to a sticker in a book. That is one of those smaller steps. So once he learns to do that, maybe he'll be able to point to things that he wants, or it'll be a way for him to engage in an activity with his parents. He can point out things in the book that he likes. So although it starts with a skill like that, that's not the overall goal. Same with the familiar people. The main goal is not for him to just be able to identify people in pictures. We want, when we say mom's here, for that connection to be made. Or I actually just had a client who we were working on something similar and we were saying dad, mom, and now he started to say them on his own after learning to point to the pictures. So you're hoping that those connections are being made and generalizing.
So from there, that was some really structured ways that we've taught certain skills, but a big focus that we do and split about half of our time with each client is in the natural environment. We call it NET, natural environment teaching. It targets skills that are more in a naturalistic play setting, daily routines, coming in the morning, hanging up your backpack, putting your lunchbox away, getting dressed, anything that could be identified that wouldn't necessarily be table work or something that would need to be sat down and taught in a structured manner, but maybe something more natural, like following models of your peers and things. The main goal for this too is to help transfer skills from a more highly controlled environment to a less controlled environment. So going back to those videos, maybe we've taught familiar people at a table with pictures of the peers that are at the center on the same day as the client. And they have then generalized that to, finding the peer in the playroom and asking them to play a game with them, or being able to even greet them in the morning and knowing who the people are around them. So that's just an example of where we could take a skill that we did have to break down a lot and make it more natural. And then the natural environment teaching should be client led. It's something where we focus on a lot of their interests. It's time for them to play, but it's a way that we can influence it, whether that's learning to play with items in a functional way or learning to request items that maybe they want to engage with, but aren't sure how to ask for them. It definitely has the ability for the technician to almost function as a peer to them. They should be playing together and interacting together. So again, some of those main goals are to incorporate the current goals into natural routines, play, and set up incidental teaching opportunities. So sometimes our therapists have to contrive situations to happen where maybe our learners don't always seek out peers to engage with, but if we get out Play-Doh and bring a couple peers to the table together, then they're more likely to interact and have those situations they can practice in. So when they go to school, they're more fluent in being able to engage with their peers. We focus on functional and meaningful learning. So does this matter for the client in day-to-day life? We're not going to teach things that aren't relevant. Some of the broken down skills might seem like the pointing, but in the end, it does have functional and meaningful skills that they can learn to be able to learn to point, or that then develops into verbal behavior. We target generalization across people, settings, and materials. So if we're learning a certain skill at the table with their group of therapists that they work with every day, can they engage in these skills with different things in the playroom or different therapists or with peers? We're looking at increasing motivation and engagement. So looking at what is a learner motivated to work for, motivated to engage with, and how can we kind of amp up that engagement so that they independently want to either request things, interact with people, show off those social skills that they're learning and being able to do that on their own. We're also looking at reducing escape and avoidance. So we want to either teach a functional way to request a break, to request something stopping or not happening, and teach them a way to either ask for an alternative or decrease them engaging in a challenging behavior or something that might not be safe before they engage in that. And then we're also looking at supporting independence. So teaching leisure skills, teaching them that this is a way to interact with a house and little characters, but if you want to engage in it your own way, that's okay too. Just giving them an opportunity to kind of explore their environment and find out what they want to do independently. So we've talked about how ABA is a blanket term, and we use a lot of discrete trial teaching, natural environment teaching, but there are a lot of other ones. And I feel like our natural environment is kind of a mix of these two as well. So there's pivotal response treatment and the early start Denver model. They're both evidence-based. They both are looking at a lot of naturalistic teaching. They're play-based and they focus on the motivation of the learner. A couple differences are that the pivotal response focuses on response to cues and self-initiation, and it definitely focuses on a broader level of improvement, while that early start Denver model is a comprehensive curriculum-based approach that is more for kids. It's limited for like 12 to 60 months. We are an early intervention clinic, so we definitely hit that 12 to 60 month range, but we do look for that broader improvement. And we as BCBAs develop a curriculum. We don't necessarily follow the Early Start Denver model curriculum. Each of our clients has a curriculum that's been identified through parent meetings, determining what is important. We talk with the schools if they are in school and determine what can we work on to make school a successful environment as well. So we have treatment plans for our kids that would be a curriculum for each of them individually. So some of the areas that we do focus on here, and many things can be added to this, but this is a pretty general list. We do look at school readiness skills. So we don't work on academic skills as we have to determine that all of our goals are medically necessary, especially for insurance. But some of that does lead to school readiness skills and working on independence for when they go to school or if they're already in school. So learning imitation skills, following instructions to participate in a developmentally appropriate task, whether we're looking at, pre-K identifying colors, shapes, common items, or even sitting with an adult to complete a task. Even if we're not gaining full independence yet at school, we're looking at how can we set a learner up to be able to, receive support from aid at school or from their teacher. We're looking at daily living skills. So transitioning from location to location, brushing their teeth, getting dressed. I have a client that I've been working on some desensitization for a dental stuff. Just different things that are identified through their daily life. This is where parent input really comes in and how we can support them throughout the day and gaining a lot of independence. Safety skills. So learning stop as an instruction if we're in a dangerous situation, learning to identify safe and unsafe situations, things that are hot, things that are dangerous. What do we do when we go to a pool? We wear a life jacket, responding to their name. If you're calling your kid's name in the house, being able for them to respond to that can tell you where they're at, and it's kind of a good safety skill. Feeding, texture aversions, trying new food, chewing, using utensils. So this only happens after they've been cleared by speech OT or another feeding specialist. We prefer to have that collaboration with speech and OT or another feeding specialist if they're seeing someone. And we really focus on that behavior aspect where we're systematically desensitizing them to food. We don't focus on swallowing or oral motor movement. That has to be completely cleared, but it's more of showing a kid maybe if they have a non-preferred foods that we can interact with it, whether we're touching it, smelling it, tolerating it being on our plate. And being able to communicate through that if it does create some challenging behavior, or the client is showing that they are upset with those foods being around. We're working on ways that we can teach methods for them to either ask that the food's not there. We don't force food on any clients or anything like that, but when we were lens students, we were able to work as a collaborative team. We had speech, OT, PT, feeding specialists, social work. And I feel like that was where we really developed a want to help as we would attend Lend clinics and they had the feeding clinics come in. There were several times that we were able to discuss with the speech and feeding specialist that there is a behavioral component of avoiding food and looking at the functions of these behaviors and ways that we could work together to target that. We focus a lot on communication, labeling, requesting, and conversational skills, decreasing in any interfering behavior, so aggression, self-injury, elopement, and social skills. So teaching peer interaction, turn taking. We do small and large group activities. So we do a circle time every morning where we sing the songs, the weather, the days of the week, things like that. And then every afternoon we have a group activity, whether they do a song and dance, they go outside and play kickball. The therapists here are responsible for creating activities for each of those every day so that they get a different experience. So overall, the goals of ABA for us are to prepare children for successful participation in home, community, and school environments. We had mentioned that sometimes our kids are only here for 1 to 3 years. Of course, that's individualized, but our main goal is to know that we personally, as an early intervention clinic, will not have these kids for a lifetime. While ABA can be effective, that's our specialty right now is early intervention. So our goal is to best prepare our kids for their future. We're focusing on improving independent responding in target areas and adding prompts and reinforcement to teach skills. And then we try to systematically fade that back so that reinforcement may not be provided constantly, or prompts that we've taught the kids then gain independence with and they no longer need to be prompted. We structure teaching with heavy prompts and frequent reinforcement, but again, we try to reduce that. So looking at a token board, we may give a token for every correct response to begin with, and then we slowly fade that away, or they have to go from earning 4 tokens to 12 tokens. Just trying to extend that to a more naturalistic level to where we're finishing a worksheet before we're getting up from the table, or we're playing Play-Doh for 3 minutes with a peer instead of just 30 seconds. So looking at what is meaningful again for each child with that. And I mentioned some functions of behavior. So some of the things we look at is every behavior has a function, and it can be more than one of these. The acronym everyone eats. So we're looking at escape, attention, tangible, and sensory functions. Escape could be the delay of a demand or getting out of a task, away from a person or environment, or stopping an activity or action. It could be tangible, so gaining access to an item or activity. Attention, which is obtaining a response from others. This could be positive or negative. And then sensory, it feels good or meets an internal need that they're looking to seek out. So our goal is to identify a behavior and determine a function. We do functional behavior assessments, looking at each condition. Does the behavior change? If we're giving attention, what is the outcome of that behavior? So when we are able to identify a function, we can create a more effective intervention by modifying the environment and our responses to change that behavior while teaching a more appropriate behavior to meet the needs. So if a client is engaging in a challenging behavior to get attention from a therapist, we could teach them instead an appropriate way to ask for attention. Or if they're looking to escape an instruction, let's say a kid is trying to run away from the table when we sit down to do some work, we could teach them to request a break or do something more appropriate where we, can delay that reinforcement when we're working on 1 or 2 tasks, then we get a break and we work on systematically increasing that for the learner. And how has that helped our clients? So We've been able to increase independent requests, labels, conversation skills for children who vocally communicate. We use a lot of AAC devices with our kids, alongside their speech pathologists too. We've had successful feeding procedures to increase a variety of food consumed. I've done a lot of feeding with kids where my main goal is for them to try a food. We can't make a kid consume a food, but the fact that they're willing to taste it and determine on their own whether they like it or not. Various pre-academic skills have been acquired and generalized, decrease in accidents and increase in successful bathroom use. We work on a lot of toilet training and decreasing problem behavior and increased functional communication, and then increases in independent interactions with peers. So the general philosophies of ABA is that everyone with autism is capable of learning. We just need to figure out how. And everyone has the right to effective treatment. The learner is always right, there's self-determination, and we use the least intrusive environment. So we mentioned like we might use a light guide. If we can teach a client to follow a model, then we'll never have to be hands-on. Ideally, we use the least intrusive method required. So if we can teach those foundational skills, then we'll never have to physically guide the client to engage in a certain behavior because we've set them up to do it more independently. That's the goal for all of this. And with the learner is always right and everyone is capable of learning, it's a reflection of our interventions if they're not working. It's not because the kid's not learning, it's because we aren't teaching the way they need. So it's our goal to figure out how do they need to learn this and what can we change to best fit their style of learning. And then this is, our resources as well as some websites that list some parent things, libraries, emailing us. We have an extensive resource list that I believe we've worked with the CED to develop too. I know they have like an interactive map of services and things on their website, but we have a wait list, of course. As we mentioned, we see kids as early intervention and they should be getting services for much longer than we can provide them. Being in West Virginia, ABA is a scarce thing to come by. We don't have a lot of resources, and that's something we're always trying to grow. How many supervisees do we have right now? 5 supervisees. So we provide that supervision, the 2,000 hours while people are in grad school so that they can become BCBAs. We've had 6 people become BCBAs since we've opened. Constantly encouraging our therapists to go to grad school and continue this, even if they don't stay with us. The idea is they're providing services somewhere, ideally in this state. But we do have a list that we can provide that if we aren't able to get a learner in, or maybe they're aged past that early intervention, that there's a couple other ABA companies around. They mostly do in-home, but that we can provide you with that information. Because as behavior analysts, it's our goal to get your kids or your clients services versus making sure they come to us. We just want people to get the help that they need. And then we do have our references for some of the things we've added. I believe this is going to be on the website, but if you ever have any questions about that, you could always email that office number and we can provide you with any other resources you may need there. So we'll open this up for questions. I know some people have typed in there. We'll stop sharing and we can kind of see where we're at.
I did put the email in there. Well, the office.
Perfect.
Thank you.
So I have a question. What's your average age that you're getting? I know there's a wait list, but what's the average age where they're starting ABA?
Typically our kids start around 2 years old, sometimes sometimes like 2 to 3, but typically, ideally, it would be starting at 2 years old. And like Devin had mentioned, like we typically only have our kids for around like 2 to 3 years, but we have kept kids longer. So it really is just based on individual need. Ideally, they would start before they were 4 for it to be most
Okay.
effective because we are early intervention. Oh, I see some people wrote some
Yes, questions.
questions. Do you ever use music therapy for teaching? Also, have you ever incorporated Legos into learning? So we are not certified music therapists, so that is something that is different, but we have had clients also go to music therapy. We have incorporated Legos in learning, like Devin and Charlotte have both mentioned. So when we're doing natural environment teaching, we're trying to use things that the client likes. So if they really like Legos, that's something that we can use to kind of get them to request for what they want, label things that they like, talk about like functions of things, or even do like,
Imitate the structure.
yeah, block imitations, a big one we do with Legos. So we always are looking for things that the client likes because in research has been proven that it's easier to learn with things that you like, which makes sense.
Music is a huge one.
Yes.
I feel like since we've started doing circle time, it's, not only everyone participating in the same activity at once, which used to be pretty rare in our center
Yeah.
because everyone had their own interests, but the kids have really learned to like the songs and will engage with them. And do the motions, and that's something that they pick up pretty quickly on as we see new clients come in. That circle time really brings them over to the group.
Yep. Especially too, like if kids like music, we're always singing to the kids, and things like playing songs that they like too. Um, so the next one says, I work with many families that have autistic children. Are there any resources I can send to the families for help? You can have them email us. So office@keylearningautismcenter.com. It's in the chat and it's also on the slides. We would be happy to send our resource list. Anything else? Oh, and you're welcome, Ramsey. Um, anybody else have any questions that we can answer for you guys? Oh, thank you. And you're welcome. We are happy to present.
If they think of any questions in the future, are they able to email that
Yeah.
and ask them? Okay.
Yeah.
Yep. Yeah, we we all check that email. So yeah, if you shoot questions over to us, you can email us at any time and we'd be happy to follow up with that or
Provide more specific resources. If there's something, if you work with certain families that you are thinking of more broad than just service questions, we can try to assist any way we can.
Yep.
All right. Any other questions? Comments? I mean, it was a great presentation. It was very helpful.
Thank you.
And okay. If there's no more questions, we appreciate you. I keep looking at the chat and talking. If there's no more questions, we appreciate you coming and presenting with us. Like I said, it was a great
anytime.
presentation, very informative. And we were happy to have you.
Yeah.
So
Thank you all.
Yeah, thank you for having us. We enjoyed it.
Yeah, the CED has a special place for us because that's where we all started. So
yeah. All right. Well, thank you so much. Have a good day.
You too.
Bye.
Bye.